Hi, it's Veronica. So today I'm going to be presenting my case study project, which is on an AP pelvis with hip. In this presentation, I will be talking about patient history and basic anatomy, technical factors and image evaluation, radiologist report and medical terminology, pathology, other related exams, and then I will be concluding with references. So this patient was 68 years old and they had come in following a fall onto their left hip. There is a history of previous surgeries that involve fixation hardware within the spine as well as an arthroplasty on the knee. So I will be discussing a trauma hip routine, which includes an AP pelvis, an AP hip, and a cross table hip, also known as the axiolateral inferior-superior hip. So going into the technical factors for an AP pelvis, you do need a 40-inch SID. You need the IR to be landscape 14 by 17 inches with a grid and the KVP to be about 80 to 90. The patient should be supine with their arms at their sides or on their chest, and the lower limbs should be rotated internally about 15 to 20 degrees unless a fracture is suspected. And this projection can also be done erect. And then the CR should be directed midway between the level of ASIS and symphysis pubis. And then here is a labeled anatomy image that shows all of the important structures of the pelvis. So moving into the image evaluation for an AP pelvis, we have anatomy demonstrated. The criteria is pelvic girdle, L5, sacrum and coccyx, femoral head and neck, and greater trocaners are visible. And then I do have a reference image of what this projection should look like. But I did say not met for this criteria because the entire left greater trochanter is not fully visible, and this is due to tilt of the pelvis and external rotation of that left lower limb due to the fracture. So you can't see that whole greater trochanter on the left here. So next we have the positioning criteria for an AP pelvis. The first one is lesser trochanter should not be visible at all. For many patients, only tips are visible. Greater trochanter should appear equal in size and shape. So I did say not met for this one because those lesser trochanters can be seen on each side, and this is because the patient was not able to internally rotate their lower limbs due to the fracture. No rotation is evidenced by symmetric appearance of the iliac alae or wings, the ischial spines, and the two obturator foramina. A foreshortened or closed obturator foramen indicates rotation in that direction. So I did say met for this one, although the ischial spines are kind of hard to see on this radiograph. The iliac wings do appear symmetric in size and shape, and so do the obturator foramen. One isn't closed off more than the other. Next, we have the right and left ischial spines, if visible, should appear equal in size. Correct centering evidenced by demonstration of entire pelvis and superior femora without foreshortening and collimated field. So I did say not met for this one because although once again you can't see those left and right ischial spines, the superior femora on the left side is not fully seen, and there's a little bit of foreshortening happening on this femoral neck on the left side because the patient couldn't internally rotate that lower limb. And then collimation to area of interest, I did say met because you can see the whole pelvic girdle, and although part of that left femur isn't on there, it's just because that leg was externally rotated, but you can still see that greater trochanter and lesser trochanter here. So next we have the exposure criteria for an AP pelvis. The first one is optimal exposure visualizes L5 in sacrum area and margins of the femoral heads and acetabula as seen through overlying pelvic structures without overexposing the ischium and pubic bones. So I did say met for this one because the exposure factors do look good. For this radiograph, there's no overexposure or underexposure, and all of the anatomical structures that need to be seen are seen really well on here. And then trabecular markings of proximal femora and pelvic structures appear sharp, indicating no motion. And I also said met for this one because there's no motion, there's no blurring, and the bones look very sharp and crisp, and all the structures are easy to see. So next we have the technical factors for an AP hip. So you do need 40 inches of SID. The IR will be going in portrait 10 by 12 inches. You do need a grid and then about 80 to 85 kVp. So the patient will be supine with their arms at their sides or on their chest, and their lower limb will be internally rotated about 15 to 20 degrees if there's no fracture present. And then the CR is going to be perpendicular to the femoral neck. And then here's a labeled anatomy image once again. You can see all of the important structures of the femur and of the pelvis here. So next we have the image evaluation for an AP hip anatomy demonstrated. The first criteria is the proximal 1/3 of the femur should be visualized along with the acetabulum and adjacent parts of the pubis, ischium, and ilium. So I did say met for this one because that proximal 1/3 of the femur can be seen along with the acetabulum and those other areas of the pelvis, and you can see on the reference image here, it looks pretty identical. And then next we have any existing orthopedic appliance should be visible in its entirety. So I did say met for this one, although in this case it would be non-applicable. So next we have the positioning criteria for an AP hip. The first one is the greater trochanter and femoral head and neck should be in full profile without foreshortening. So I did say not met for this one because although the femoral head and neck are in profile, there appears to be a good amount of foreshortening in my image compared to the reference image, but that is due to the inability of the patient to internally rotate their lower limb because of the fracture. And then next we have the lesser trochanter should not project beyond the medial border of the femur. Collimated fields should demonstrate the entire hip joint and any orthopedic appliance in its entirety. So I did say not met for this one because although that hip joint is demonstrated, the lesser trochanter is very medially projected, but that's also due to the inability to internally rotate that lower limb. And then collimation to area of interest, I did say met because you can see all of the structures that you need to see and the collimation looks good. It looks very similar to that reference image. So next we have the exposure criteria. So optimal exposure visualizes the margins of the femoral head and the acetabulum through overlying pelvic structures without overexposing other parts of the proximal femur or pelvic structures. I did say met for this one because the exposure in this image does look really good, and there's no overexposure or underexposure in any of the areas, and all of the anatomic structures can be seen very well. And then trabecular markings of the greater trochanter and neck appear sharp, indicating no motion. And I did say met for this one because no motion is evident by no blurring, and the bones look very sharp and crisp, and everything can be seen very well. Next, we have the technical factors of an axiolateral inferior-superior hip. So once again, you need 40 inches of SID, a 10 by 12 IR landscape. You do need a grid, and then you need about 80 to 95 kVp. So the patient may be on the stretcher or bedside, but the pelvis will need to be raised about 1 to 2 inches with support underneath. You can use like a towel or something. And then the unaffected leg needs to be flexed and elevated to get it out of the way. And then the affected leg needs to be internally rotated about 15 to 20 degrees. And then the CR will be perpendicular to the femoral neck and IR. And then here's a labeled anatomy image. You can see that femoral head here, and then that proximal area of the femur, and then everything labeled. So image evaluation criteria, anatomy demonstrated for a cross-table hip. The entire femoral head and neck, trochanter, and acetabulum should be visualized along with any orthopedic prosthetic device in its entirety. So I did say met for this one because you can see the entire femoral head, the acetabulum, the greater and lesser trochanters, and a good amount of the proximal femur. And then here's just a reference image of what a good cross-table hip should look like. So moving on to positioning, the first criteria is only a small part, if any, of lesser trochanter is visualized with inversion of affected leg. And I did say met for this one because you can see here that lesser trochanter, only a little bit is seen. It's actually kind of hard to see on this image. And then next we have only the most distal part of the femoral neck should be superimposed by the greater trochanter. And I also said met for this one because you can see the neck here, and then you can see just a little bit of that greater trochanter superimposing that distal part of the neck. And then next we have soft tissue from raised unaffected leg is not superimposed over affected hip if leg is raised sufficiently and CR is placed correctly. No grid lines are visible. So I did say not met for this one because there is a good amount of soft tissue superimposing the affected hip, which means that the unaffected lower leg was not raised sufficiently. You can see all of that soft tissue here, making it harder to see that affected femoral head and neck and proximal part of that femur. And then collimation to area of interest, I did say met for this one because you can see all of the structures that you need to see on this image. And then here's just a reference image, and you can see that the collimation looks pretty similar for both. And then lastly, for exposure, the optimal exposure visualizes outline of entire femoral head and acetabulum without overexposing the neck and proximal femoral shaft. And I did say not met for this one because this image does appear a little underexposed, as it is hard to visualize the head of the femur, so more technique could have been used to better penetrate the body part and produce an image with optimal exposure in this case. So next we have the radiologist report, and under findings for chest, it says median sternotomy wires, partial visualization of cervical fixation hardware, patchy left basilar opacities, no pneumothorax, borderline enlarged cardiomediastinal silhouette, questionable minimal pulmonary vascular congestion. And then for that hip, it says comminuted displaced left intertrochanteric femoral fracture, extending to the proximal left fibular diaphysis. The left femoral head remains seated in the acetabulum. The pelvic rings are intact. Left knee arthroplasty hardware appears intact. No periprosthetic lucency to suggest loosening. No suprapatellar joint effusion, and extensive vascular calcifications noted. So next I have some med terms that I found in the radiologist report with reference images. So sternotomy wires are stainless steel wires a surgeon uses to hold the two halves of the sternum together after heart surgery. Pneumothorax is the presence of gas in the pleural space, which allows the parietal and visceral pleura to separate and the lung to collapse. Arthroplasty is the procedure that reconstructs or reforms the articular surface of a joint. Paraprosthetic lucency is the indication of bone deterioration next to a prosthetic implant, and it's usually seen as dark on an X-ray image. And then cardiomediastinal silhouette is the outline of the heart as seen on a chest X-ray and forms part of the cardiomediastinal contour. So the pathology that I will be talking about is a comminuted displaced intertrochanteric femoral fracture, which is an extracapsular fracture of the proximal femur that occurs between the greater and lesser trochanters. The bone is shattered into multiple pieces and has shifted out of its normal position. And this fracture usually occurs in both young and elderly people. However, it occurs more commonly in the elderly because their bones are more brittle, so when they fall, it's easier to be fractured. So going into the symptoms and diagnosis, the main symptoms include severe pain in the hip or groin, swelling and bruising around the hip, inability to bear weight on the injured leg, unable to stand or move after the fall, pain and stiffness in the injured leg, and the affected leg being externally rotated. And then for diagnosis, the doctor will review the patient's symptoms and perform a physical examination first. And if a fracture is suspected, then imaging exams will be done, including either X-ray, CT, or MRI. So next we have treatment. So in some cases, a patient can't have surgery because they have a high risk of perioperative mortality, but in most cases, the patient will have an open reduction internal fixation. So in this case, an intramedullary nail is used when fractures are involving the lateral femoral wall, or if there are unstable patterns such as comminuted, thin lateral wall, or displaced lesser trochanters. And arthroplasty is reserved for severely comminuted fractures, osteoporotic bone, degenerative arthritis, or the salvage of internal fixation. In some cases, screws and a metal plate may be used instead of a nail. So the prognosis of this pathology does depend on gender and age. So males usually have a higher mortality rate compared to females, and then usually the risk of death increases, especially over the age of 85. And then in patients who are treated non-operatively, cardiopulmonary, thromboembolic events, and sepsis are the most common complications seen. But some people do make a full recovery and return to normal activities after having surgeries. So next, going into the radiographic appearance of this pathology, so there is a presence of multiple small bone fragments at the fracture site, and these pieces may be displaced from their normal alignment, with the distal fragment often displaced medially and rotated externally. So here's my image along with a reference image to kind of show these displaced fracture pieces, and they're out of their normal alignment, as you can see here. So next we have other related exams. So this patient did have fluoroscopy images obtained because they did have surgery on this fracture. So usually a short rod and screws are used to realign and hold the proximal femur in place. Intertrochanteric fractures are treated surgically with either a sliding compression hip screw and side plate or an intramedullary nail. In this case, an intramedullary nail and screws were used. And these fluoro exams are crucial for guiding the placement of these surgical implants to achieve proper fracture reduction and stabilization. And then I do have a reference image here that kind of shows the intramedullary nail and how it goes down to the mid-femur, but in some cases it may go all the way down to the knee. And then here are the fluoro images of my patient. So you can see that intramedullary nail, a rod, and then here's a screw that goes into that femoral head to kind of keep that fracture in place. So in this presentation, I went over patient history, basic anatomy, technical factors, image evaluation, radiologist report and medical terminology, pathology, and other related exams. To conclude, here are all of my references. Thank you.